Welcome everyone to the webinar on advances in EGFR Metastatic NSCLC, current advances, outcome, and evolving strategies. To start with the proceedings, I would like to call our program director, Dr. Biswas, to start with the proceedings. Sir is a senior consultant medical oncologist at Apollo Hospitals, Kolkata. Over to you, sir.
Thank you for the introduction. Very good evening to everybody who has joined for today's webinar. So today's topic will be on advances in EGFR mutation positive advanced NSCLC and the current evidence, outcome, and the evolving strategy. I think if we discuss about all the research and development and the outcome, lung cancer has been the poster boy thanks to the discovery of many targets and the novel target therapy. Now we have seen patients living for longer life with a good quality of life, even in stage 4 disease. And maybe we are heading to cure in many of them. EGFR mutation positive advanced NSCLC is one of them. And this landscape is rapidly changing. Then initially came the TKI. Now we are living in the era of third generation EGFR TKI, combination therapy, the bispecific antibody, and the outcome is changing every year. It's a rapidly changing landscape, and now we have to customize the treatment. And in today's webinar, we have many discussion on that, case-based presentations followed by panel discussion. We have international speaker today. I'll welcome Dr. Ernest Nadal. He will be our international guest speaker for today's program. So he is a very famous international medical oncologist. He is the head of thoracic tumor section of the Catalan Institute of Oncology, associate professor at the University of Barcelona. He is a leading medical oncologist and internationally recognized expert in thoracic malignancy, special focus on lung cancer, mostly EGFR positive lung cancer, also with the brain metastasis. He has done many pioneer work in clinical research, translational research, many peer-reviewed publication, national, international journal. He's a very well recognized, has done many works, research works in this field, in the immuno-oncology combination, the target therapy, the brain metastasis biology. He is leading members of the many international societies. So it's a privilege to invite Dr. Ernest Nadal to present his insight on management of EGFR mutation positive advanced NSCLC. So thank you once again and welcome Dr. Ernest Nadal. The stage is yours. Thank you, sir.
Thank you so much, and good evening, everybody. Thank you, Dr. Biswas, for this overwhelming and very nice and kind introduction. And I will be delighted to be with you in India today, but due to agenda constraints, I was not able to travel. But I will try to do my best and have a very nice exchanging session today about EGFR. Let me share my screen for a moment, and I hope everything goes well. Okay. Could you see well the slides?
Yes.
Okay. Okay, then let's start. I have prepared a presentation for the first half an hour, and then we will have questions afterwards. And I think we will have other talks from other colleagues from India. And at the end, I think we will have more discussion. I would like to start a bit, 1 second. Now these are my conflicts of interest, and I would like to start first with a historical note. I think lung cancer, as Dr. Biswas commented, experienced a impressive and significant change in terms of prognosis and number of treatments that we can deliver to our patients. And EGFR is an important benchmark in the history of lung cancer. It was discovered, as you know, in 2004. It is close, but this is far also, more than 20 years ago. As you know, 3 different labs were able, in the US, were able to discover this mutation that is really important for us because it was the first targeted therapy that came in this disease. Now we have more than 10 different actionable alterations identified in lung cancer, but this was the first, and this is why for us it's quite significant. And one of the we could say mysteries, or one of the nuances that belongs to this biomarker, this important alteration, is that the distribution in the world is not even. And we know that for example, here in Europe, the incidence or the frequency of EGFR mutations is around 10%, 15%. But in Asia, particularly in China or Japan, the frequency is much higher. Is half of the patients with lung carcinoma may harbor an EGFR actionable alteration. That means that when you are in the clinic, one out of two patients coming to the clinic harbors one of these alterations. We have also some data coming from India. I have found this publication from several doctors, important doctors in India, that analyze several publications, and they refer that they reported that in India there is an the estimated frequency of EGFR mutations in patients with lung adenocarcinoma is about 40%, and it's more likely to happen to find this alteration in females and non-smokers. And exon 19 was more common than A58R. That is a difference with China and Japan, that they have significantly high incidence of exon 21 mutation. But the history has been a history of success. But I would like to do some historical comments, because when I was a resident back in 2002, we have been using gefitinib and erlotinib in patients that were not selected based on the EGFR alteration, because we didn't know that these alterations exist. But it was nice to see that when at that time there were some initiatives that we commented doing research on patients that they have extreme responses to targeted therapy. Those labs were able to identify the alterations in EGFR. And from that moment in 2004, I think the history completely changed, and we will do a short review now, and we will focus on the current landscape. This is a slide to show that after EGFR was identified, and after the IPAS trial, there was a really important study that demonstrated that it's very significant and it's very relevant to identify the patients that they have the EGFR alteration, because these are the patients that they benefit from this targeted therapy. And we have had different clinical trials in which EGFR TKIs were compared with chemotherapy. The first trials came with gefitinib and then erlotinib. And then we have also second generation EGFR inhibitors, afatinib and dacomitinib, that were compared with the first generation. And it's true that at that time we were quite enthusiastic about the second generation EGFR TKIs, but they came with a significant toxicity, and it's true that dacomitinib demonstrated significant improvement in terms of PFS. But then osimertinib, that was at that time being used as a salvage therapy in patients with EGFR T790M mutation, came to the front line based on the FLAURA study. Here you can see the benchmark of the PFS data, and you can see that in the blue arrow, there's the median PFS in the FLAURA study with osimertinib, achieving 18 months of median PFS. That was much more than the first generation EGFR TKIs. At that time also there were another strategies like erlotinib plus bevacizumab or erlotinib plus ramucirumab that confer also significant advantage in terms of progression-free survival, but they were not able to demonstrate what osimertinib demonstrated at that time. That was also a significant improvement in the overall survival. Then let's review shortly the FLAURA study that you all know. And as you know, in this study, osimertinib was compared with gefitinib or erlotinib in patients with common EGFR mutations. It was a global study that was conducted in different countries of the world, also some countries from Asia, but also from Europe. We were able to participate and enroll few patients. And the study was really important because it was demonstrated in that study that osimertinib was superior to the first generation EGFR TKIs, not only in terms of PFS, but also in terms of overall survival. Here you can see the Kaplan-Meier plot. But there were some interesting observations in the subgroup analysis. You can see that there were few populations of patients that they have a lower benefit, and those patients were Asian patients and patients with EGFR with the exon 21 mutation, probably because those patients, they have a different biology, and these tumors could be more aggressive, and in general, they have a shorter benefit in terms of PFS. And that is something that is just an observation from this exploratory analysis, but I think that is something interesting for the discussion afterwards. Then the FLAURA was also really important because it was also the first study that demonstrated a really important effect in the central nervous system. There were some preclinical studies showing that osimertinib, due to the biochemical structure and its ability to penetrate in the brain, it could deliver significant activity in this compartment that we know that is really important in this disease, because there are many patients that may have brain metastases at diagnosis, or they could develop these lesions, these brain metastases over the course of the disease. And in the exploratory analysis conducted in FLAURA, in terms of the intracranial efficacy, the intracranial response rate in the brain was much higher with osimertinib compared with clefitinib and erlotinib. But not only in terms of overall response, it was also an important effect in terms of intracranial progression-free survival, and also in terms of the appearance of new lesions, which this is one of the main problems that we can observe in EGFR mutant patients. And that was probably one of the important assets that this drug delivered to the patients, because I think this is a major difference. It was not only the best tolerability compared with the first and second generation of the drugs, but also the higher efficacy in the CNS that is really important to achieve longer survival. But one of the problems we have with osimertinib is that we know that most patients will progress after the first year of therapy. The median PFS is about 18 months, and we know that the patients can develop mechanisms of resistance, mainly on target and bypass resistant mechanisms. But some of them, they can also experience histologic transformation. That the only way that we can identify this mechanism is if we perform a tumor biopsy upon disease progression. And this is something that we need to have access to doctors that could collaborate with us to get these biopsies, and also have a low threshold in terms of we have a patient that is progressing quite fast to osimertinib, particularly with lymph nodes in several areas of the body, particularly in the thorax. Is important to do a biopsy and identify that, and be able to check if they still have lung adenocarcinoma, or they have a transformation to another histological type like squamous cell carcinoma or small cell lung cancer. But what has been reported based on the FLAURA study is that the most common mechanisms observing patients were the acquisition of novel mutations in the EGFR domain, particularly in certain of the protein translates in a different conformation of the protein that with EGFR. And the most common is the mutation located in the 797 position. That is one of the most common, but it's true that we only find this alteration in 6% of patients. And other mechanisms that have been characterized is the appearance of amplification. So that is one of the most common. Can acquire another mutations like in genes that are important in lung cancer, like BRAF or KRAS or PI3K. But other alterations could be the acquisition of amplifications of another genes, like, for example, the cyclin, the CDK4 or CDK6. But from those alterations, very few at this moment are currently actionable, mainly MET and some of the novel mutations acquired in EGFR. But this is coming from FLAURA, and other studies have been conducted that have been developed based on real-world data analysis, and so many of them, they reproduce the results. And I think in my practice, I think it's important when I am able to do it and the patient accepts well that I think it's important to do a tumor biopsy or a liquid biopsy to try to understand the mechanism of resistance to osimertinib when in patients, because that can help me to guide better which is the treatment that I will deliver in the second line. But what happens with osimertinib in the real clinical setting? I bring this study to I wanted to share with you this study recently published in JTO, that is a retrospective study based on more than 1,000 patients with advanced EGFR mutant non-small cell lung cancer with a long follow-up of 20 months, and the median real-world overall survival is 28 months. And you can see here that there is a decrease of the survivors after, that is really important, after 2 years. You can see that the 3-year overall survival rate is about 41%, but the 5 years overall survival is only 18%. That means that we have been quite enthusiastic in this disease, because I think we got a significant advance during the last decades, but still we have a lot of work to do to increase the number of patients that are long-term survivors. We compare those numbers with the numbers we have with ALK-positive disease. We still have to work hard to try to improve the survival of patients. And another observation that to me was really interesting from this real-world study is that about a third of patients that they progress to osimertinib, they don't receive any therapy in the second line. That means that we maintain osimertinib beyond progression, and at some point the patients, they have a decline and they don't receive any other therapy beyond osimertinib. And I think that's an important message that I think it represents well what I see also in the clinic. And in that study, I think it was also interesting that the authors were able to identify few prognostic factors that are reflected here in the table, like patients that are elderly, they have brain metastases, they have an exon 21 mutation, they have liver mets and a poor performance status, and also a p53 concurrent mutation. They have in general worse overall survival. And these are patients in which we can consider to do something different that we will discuss now. And if we compile all these alterations as it is represented in this graph, in this slide, it's quite easy to identify patients that they have at least one of these characteristics of poor prognosis, like elderly patients, exon 21, PS2, brain metastases, liver mets, p53 commutation that is quite common in this subset of lung cancer. About half of the patients, they may harbor these alterations, and also circulating DNA positive that is also reflecting a higher burden of the disease in the body. Then I think a significant fraction of patients, they can have a very aggressive disease, and probably osimertinib alone is not the best way to go. But we can discuss that in a moment. And then how we can improve the survival outcomes and delay the tumor progression of this disease. And one of the strategies, the most obvious, was to use the best drug at the beginning, and that was what we did after FLAURA, that we incorporated osimertinib in the front line. But then another strategy that was investigated was to intensify the therapy in the front line, combining TKI, EGFR TKIs with chemotherapy, or combining EGFR TKIs with monoclonal antibodies targeting angiogenesis, or other bispecific antibodies targeting EGFR and MET, as we will discuss later. Obviously, what we can do also is to identify patients that they progress early on, and then characterize the mechanisms of resistance and deliver another therapy. But I have the feeling that when we do that, we are always running behind the disease. I think one advantage of doing that intensified therapy at the beginning is that we can exert more pressure in the tumor, and that could, as you will see later, that could be an interesting strategy for a significant part of patients. But talking about combinations, before talking about FLAURA2, I would like to remind that obviously, the FLAURA2 was not built based on from scratch. There were a couple of studies coming from Japan, and also another important study coming from India, from Dr. Noroña and many other doctors from India that participated in that very nice study, in which chemotherapy, carboplatin pemetrexed, was combined with gefitinib and was compared with gefitinib alone, and both studies demonstrated an amazing activity in terms of PFS. The risk of progression of death were reduced to 50%. And also in the Indian study, there was a very nice result in terms of overall survival improvement. And that was published a few years ago. As you know, we could say many years ago because time flies. But it was an important and provocative result at that time, because we were expecting that maybe these combinations could not fly well. But then the next step, obviously based on that, it was to combine the best drug that we had in the front line, that was osimertinib, with chemotherapy. And that was the rationale for using FLAURA2. One was trying to intensify the therapy because we know, as we discussed before, that 1/3 of the patients, they don't receive a second-line therapy. And we know that many patients, they have poor prognostic factors, that they could have a very aggressive evolution on monotherapy. And in the FLAURA2, patients with non-squamous, non-small cell lung cancer, harboring a common EGFR mutation, exon 19 or exon 21, with a good performance status, were randomized to receive osimertinib alone, the standard of care at that time, versus osimertinib plus chemotherapy, consisting on carboplatin or cisplatin combined with pemetrexed. And then after 4 cycles of platinum, the maintenance with pemetrexed was maintained was combined with osimertinib, and this therapy was sustained until tumor progression or unacceptable toxicity or patient or physician decision. The primary point was progression-free survival by the investigator based on RECIST. And I would like to highlight that the stratification factors were race, ECOG performance status, and the type of testing of EGFR, local versus central. One criticism to that study is that it was not stratified based on brain metastases. That was something that probably would make sense, but it was not designed like this. And you know that the study was well balanced. There was a representation from the whole globe. There were patients from Asia and from the rest of the world, and the proportion of patients with exon 19 was higher, 60% of patients, and the proportion of patients with brain metastasis was really high, 40%, and that was well balanced between both arms. And the study was positive for the primary endpoint, demonstrating a significant benefit in terms of progression-free survival of more than 8 months, 8.8 months, with a hazard ratio that was very impressive of 0.62. But at that time, we have discussed a lot if that makes sense. We will discuss later with you what do you think, but I think the benefit was very consistent across all the subgroups that were analyzed in this exploratory analysis. You can see that patients benefit from the combination independently of the type of mutation, and also there were a couple of signals that to me they're really interesting. The patients with a performance status of 1 and the patients with CNS metastases, they have significant benefit, probably because these are patients that they have high tumor burden and poor prognosis, and probably they have higher risk of not receiving a second-line therapy. And these are patients that we can later discuss if they could be candidates for this approach. The overall response was similar between both arms, but what it was significantly extended, it was the duration of response. That with osimertinib alone was 15 months, but the median duration of response with osimertinib plus chemotherapy was 24 months, was significantly higher. But there was a cost of the combination in terms of toxicities, and we observed higher grade 3 or grade 4 adverse events and treatment-related adverse events, as well as severe adverse events with osimertinib plus chemotherapy. And that was something that we could expect because we are adding chemotherapy to osimertinib. But in terms of toxic deaths or grade 5, there were no major differences because most of the toxicities that were observed were hematological. As you can see in this graph, the proportion of patients with grade 3 for anemia or neutropenia or thrombocytopenia was much higher when we add chemotherapy, but most of them are well managed by oncologists, and it's true that they may have impact on patients in terms of support, transfusion support, red blood support, or some patients they needed to be admitted in the hospital because they had infection. But it's something that we should discuss with our patients. But it is interesting that the combination did not increase the incidence of interstitial lung disease. There were no more pneumonitis in patients that is already pretty rare with osimertinib alone, but that was not modified when we add chemotherapy. And there is also an interesting kinetics of the toxicity. You can see that most of the toxicities are seen during the first period when we use platinum-based chemotherapy. Once the patients interrupt the platinum induction and during the pemetrexed maintenance, the number of adverse events is lower and is in general quite well tolerated. But some patients they require interruption of chemotherapy, and once they interrupt chemotherapy, they continue on osimertinib. But the addition of chemo to osimertinib had minimal impact on the rates of osimertinib discontinuation. And that to me is very important because we don't want to compromise the targeted therapy, and because that could be an issue in some patients that we know that if they interrupt osimertinib for a while, they may experience a tumor flare. There was also an interesting result that is, it was something we could say unexpected, that the efficacy in the brain was higher when we use osimertinib plus chemotherapy. The differences in terms of the intracranial overall response rate were not very significant, but there were more complete responses in the brain, 59% when we combine osi plus chemo, compared with 43% when we use only osimertinib. And there was also an improvement in terms of the intracranial PFS with a hazard ratio of 0.58. I would like to remind that brain metastasis was not a stratification factor, but the patients were quite well balanced in terms of CNS disease in both arms. There were no major differences in terms of the appearance of new lesions when we add chemotherapy, and that is not surprising, that because osimertinib alone is already a good, can act as a protector for the central nervous system, and chemotherapy doesn't seem to add much in this setting. The benefit is more coming from in patients that they already have brain metastases. And we were expecting for a few months. It was presented at ESMO in Berlin in October. That was the overall survival of the FLAURA2 study, that we have seen a significant improvement in terms of overall survival with a hazard ratio of 0.77. And you can see that at 3 years, the overall survival rate went from 51% to 63%. And that was maintained at the 4 years landmark analysis with an improvement of 8% in the overall survival rate. That to me is very important because at the beginning we were discussing a lot based on this study that we don't know if adding chemotherapy is just adding more toxicity and we were improving PFS, but we were not sure if we could improve also overall survival. But that was demonstrated. And to me, that is important because then when I have patients in the clinic, I think we should consider that osi plus chemo could be is a new standard of care that we need to take into account. In terms of the exploratory analysis based on the different subgroups, we can see that most of the subgroups benefit also from the combination. There is a trend, but there was an exploratory analysis. But I think it's important also to see that patients with for example, liver metastasis or patients with exon 21, they have more aggressive disease and they benefit also from this combination. And at ESMO, it was also presented by Dr. Jane, an exploratory analysis that was supporting that most of the poor prognostic groups, they retain the benefit of the combination. I would like to highlight that these are not predictive factors, these are prognostic factors. But that could be helpful for us to decide when to use OSI plus chemo, but they are not completely demonstrated as a predictive factors. And I think it's important also to take into consideration always the patient preferences. In terms of post-progression treatment, chemotherapy has been the most common treatment in both arms. That is not surprising because also patients with OSI plus chemo, some of them, they interrupt chemotherapy and then, or they maintain pemetrexed for a while, but then when they progress, as they progress very late, we can consider to rechallenge platinum-based chemotherapy. That is what happens a lot in the study. And what happens in the control arm is that patients receiving osimertinib alone, most of them, they receive carboplatin pemetrexed when they progress afterwards. But this is not the end of the story. There are other interesting also approaches to the front line, and we will focus on another strategy that I think is very also, but I think it's also a different approach that is to combine lazertinib, another EGFR TKI, that I think not targeting EGFRm MET. But another strategy that has been also investigated mainly in Japan is the combination of osimertinib plus ramucirumab. That this combination has not been very promising based on the data we have seen so far. But I would like to comment briefly the data coming from Mariposa. It was another study that also demonstrated in the front line that amivantamab plus lazertinib can improve PFS and overall survival compared with osimertinib. And that was something that was also very impressive, with a hazard ratio for PFS of 0.7 and a hazard ratio for overall survival of 0.75. Despite this study has not been updated, and we don't have long-term overall survival data that we have seen with FLAURA2, and I think that's a limitation from my perspective, from my point of view. Another challenge of Mariposa is that we need to be sweet to a different range of toxicities, mainly derived from the EGFR inhibition in terms of skin and GI toxicities. The dermatitis, the rash, and the paronychia could be very important. It could be grade 2 or even grade 3 in some patients. That could be sometimes difficult to tackle for patients and also for clinicians. And we need to collaborate closely with dermatologists to control those toxicities. And for patients that they derive significant benefit and they maintain the therapy for a long period of time, the MET inhibition is also a problem in terms of the appearance of hypoalbuminemia and edema that makes us to interrupt the therapy and is not responding well to diuretics in general, and that can also affect the quality of life. And in many countries now, amivantamab is available that can be delivered in the subcutaneous way that is more convenient for patients, and we can skip infusion reactions. But still in many countries it's being used in IV, and that is another problem that for patients it could be not only for patients, for the hospitals, because some of the therapies can be prolonged and that could affect how we organize the outpatient clinic. And also many patients, they require anticoagulation because there is a high risk of thrombosis. And that makes that using this combination is very interesting, but it requires a lot of effort and is also probably costly in many countries. For example, in Spain, it has been recently reimbursed, but we have been using more FLAURA2 approach. because we are more suited to manage the toxicity related with chemotherapy. But we are also using in some patients the Mariposa approach, but it's only a minority. And we check how the landscape evolved. I think it's amazing that now we go to the small living guidelines in the last version. The list is growing, and we have beyond osimertinib in monotherapy, we have now osimertinib combined with chemotherapy with a magnitude of the clinical benefit scale of 3. And also we have lazertinib amivantamab as an alternative. And I think it's important in this setting that we need to take into account different factors, some factors related with the disease, in terms of how much tumor burden the patient has. For example, if the patient has liver mets, brain metastases, and if the patient is quite sick, that could be a problem in terms of using combinations, because that patient could be a bit more frail. And I think sometimes there is this problem in the clinic that you have a patient with higher tumor burden, then you think it's good to go for a combination, but that patient is more sick because he's having more symptoms. And that is, I think it's important to have a good palliative care approach and improve how the patient is coping the disease, because then we could deliver the best therapy to those patients. There are also molecular factors. We know that patients with exon 21 concurrent p53 alterations, they have a more aggressive biology. And as I mentioned before, this is not a predictive factor, but to me it's also an important factor that I took into account. And then it's important to see also the patient we have in front of us in terms of comorbidities, age, and also to me it's very important the patient preferences. And I think there is still a fraction of patients in which we could consider osimertinib monotherapy. Now, before going to the discussion, I would like to mention a bit what we can do afterwards, because that is something that is also evolving fastly, and we have now many other options. And we know that when a patient is progressing to osimertinib, I think it's important, if the patient is progressing only in few sites or one site, and that is confirmed in the PET-CT or the brain MRI, we can consider delivering local therapy and continue osimertinib. And I have some patients that with this strategy, we have been controlling the disease for years. But there are patients that they have a more aggressive behavior, and then the disease is progressing in different sites. And I think in this scenario, it's important, if we have access to NGS, to perform a new biopsy. In that biopsy, is important, what we discussed before, to tease out that the patient is not experiencing an histologic transformation. And once that is discarded, I think it's important to do an NGS to see if we can identify the mechanism of resistance, and this information could be potentially helpful, potentially relevant to guide the best second line approach. But in many occasions, we are not able to identify the mechanism of resistance, or we don't have access to NGS or to liquid biopsy, and we need to be more pragmatic. And in this scenario, also, we have different options that are becoming new standard of care, and I would like to discuss with you shortly. If we do have access to NGS and liquid biopsy, we can do a rational approach, and then if the patient has histologic transformation, we can combine platinum-based chemotherapy with etoposide, and in some cases you can consider to maintain the TKI. If we identify a bypass track mechanism, for example, a BRAF mutation or some mutations or an ALK fusion or a RET fusion, there are some publications showing benefit of combining osimertinib plus another drug. And then patients with on-target mutations, we can consider a 4th-generation EGFR TKI. But there are other options that we can also consider that I will discuss shortly now. I think the addition of immunotherapy has been investigated, particularly when it's combined also with an antiangiogenic, and that can improve the progression-free survival. This has been shown in different studies, the Empower 150 or the Orient 31. But then in all these studies, there was a delusion because the addition of antiangiogenic agents plus immunotherapy plus chemotherapy did not improve the overall survival. But novel drugs are coming to the field, like, for example, the bispecifics that are targeting VEGF and PD-1 or PDL1, like ivonescimab or pumitamig. And you can see here some studies that has been presented the last 2 years. For example, the Harmony A that was conducted only in China with ivonescimab in patients with EGFR mutant disease progressing to osimertinib, and the study was positive in terms of PFS and overall survival. But then the Harmony Global study was also positive in terms of PFS, but the results in terms of overall survival were a bit more disappointing. And there is also some preliminary data coming from China with another bispecific, pumitamig or BNT327, that yield an interesting activity in this population of patients when it's combined with chemotherapy. Another option could be to use amivantamab in combination with chemotherapy, and we have data coming from Mariposa 2 demonstrating that the addition of amivantamab to chemo can increase the overall response rate and also the median PFS, but also the overall survival. What is not clear in this setting is that adding lazertinib in
Sir, just a gentle reminder. So we are running 10 minutes, 5 minutes behind. So
Okay, I will end soon. I will just wrap up in a moment. And then we have also some ADCs that are coming to the field. One of them is the datopotamab deruxtecan, that it has been shown that it has promising efficacy in patients with EGFR mutant non-small cell lung cancer, with a median PFS of 5.8 months and a median OS of 16 months. And this has been approved already by the FDA in the United States. Another combination that has been tested, it was the combination of dato-DXd plus osimertinib in the Orchard study that was presented last year at ELCC, and it has also demonstrated promising efficacy. And another ADC that is also showing very interesting results is another ADC targeting TROP2, that is sacituzumab tirumotecan, that in the OptiTrop Lung 4 study, it was compared with chemo, and that ADC demonstrated a significant benefit in terms of PFS and overall survival. And another drug that is also at a very early stage is the EGFRm, that is a bispecific that is also an ADC, and it has shown that in patients with EGFR mutant disease, it could achieve an overall response rate of 63%. Then I think we are assisting a moment that is really interesting in terms of novel drugs coming to the second line setting that could also expand and benefit many patients. And this is my last slide. Just this to open the discussion. I think it is important when we have a patient with EGFR mutant disease in the clinic, we need to take into account different factors. I already mentioned the patient preferences and how the patient is doing, which is the disease burden, the molecular information, and also there are another factors like which is the drug availability, and in many countries there are also some constraints in terms of access to the therapy that is something that could limit the way we treat the patients. But it's true that we have now a couple of studies that demonstrated benefit over osimertinib, and I think it's true that the toxicity is increased, but I think that is a new standard of care that we need to take into account, and we need to be open to discuss these options with our patients. And this is my last slide to thank all the team that I have the privilege to work with, and thank you for your kind attention, and sorry for being a bit late.
Thank you, Dr. Nadal. It was an excellent discussion on all aspects of management of EGFR mutation positive advanced NSCLC, especially the post-osimertinib failure approach. Lots of things happening. As of now, ADC is taking the place other than the amivantamab. So we'll have a discussion on that on the management in a panel discussion. Thank you once again for this vivid discussion, the elaboration on the management part. So be with us. So now we have two case discussion. First case will be presented by Dr. Abhishek Tiwari. He's a consultant medical oncologist, Regency Hospital, Kanpur. And after this case, we have a small moderation with panelists. We have two panelists for this case discussion. So I'll invite Dr. Abhishek Tiwari to present his case, and then at the end of the presentation, I'll invite two of my panelists. Dr. Abhishek, are you there?
Yes, sir, I'm there, sir.
Yeah, please go ahead. Good evening.
Sure, sir. A very good evening, everyone. My name is Dr. Abhishek Tiwari. And first of all, before beginning with my case, I would like to thank the organizers, especially Biswas sir, for giving me this platform and opportunity. So please, can we have the next slide, please? So this is the 55 years old male Caucasian who has never smoked, no significant past medical histories there, no significant family history. He presented to the hospital with a shortness of breath for a couple of months and developed worsening chest pain. Chest X-ray was done by the respiratory team, and henceforth they presented to the site. Next slide, please. So a further evaluation was done on the basis of CT scan, and we found a left lower mass with having a venous tunnel and a hinal lymphadenopathy. Along with that, the patient also had a bone mets as well as an adrenal mets. On biopsy, further, we find out to be an adenocarcinoma, NSCLC, and an NGS was thus ordered, and probably an hotspot NGS or an maybe a CGP was done, and was found that yes, the patient was a non-smoker. We found an oncogenic driver mutation here, which is in the form of EGFR L858R mutation. And interestingly enough, we also have a PDL1, which is around 70%. Next slide. So further, a brain MRI was done, which showed no brain metastasis. So this baseline MRI is present on the right side of done on April 22. Next slide, please. The patient was started on the first line of the treatment, that is osimertinib, which is a third generation TKI, and a partial response was achieved after 3 months. On the left side, we can see the CT scan at the baseline, and after 3 months, there is a partial response. Next slide, please. So in this slide, we discuss the outcome of the management. So adverse effect was observed with the use of osimertinib. So a grade 1 rash was appeared over the trunk and upper limbs. And then again, a grade 1 fingers paranoia was appeared, and a grade 1 diarrhea was also there. And these adverse events were managed symptomatically and conservatively. Alomient creams was used, topical steroids were used, and loperamide was used as per the need. Next slide. And so if you look at the follow-up, a repeated CT scan was done in November 23, and it shows a disease progression. And as we have seen in the last slide, there was an achievement of a partial response. So on the left side, we can see the CT scan of the best response, while the latest CT scan shows the progression of the disease. Next slide, please. Thank you.
Thank you, Dr. Tiwari, for presenting this case. So we have a small panel discussion after this. We have 3 panelists, but Dr. Chandragouda could not be joined because of some emergency. So I'll invite our 2 panelists, Dr. Kunal Jain, Associate Professor Medical Oncology from Dayanand Medical College and Hospital, Ludhiana. And we have Dr. Sandeep Ganguly, Senior Consultant Medical Oncologist from Apple Hospital, Kolkata. So Dr. Kunal, Dr. Ganguly, are you both of you there?
Yeah, yes. Good evening.
Hi, good evening.
Good evening.
So, sir, good evening to all of you. So, if this case diagnosis today's time, So my first question to Dr. Kunal sir, would you manage differently? I'll just discuss the first line management. So Dr. Tiwari has treated with osimertinib. What will be your choice in today's time?
Yeah, so this is a 55-year-old gentleman who seems to be quite fit as per the presentation that was shown. If you see the scan, the lung disease volume also seems to be very less, so he should be otherwise relatively, although it was mentioned that he had chest pain and breathlessness, but uh, on those images itself, the disease burden does not seem to be very large. So I
PS1,
would,
let's say sir,
yes,
PS1.
PS1. So I would consider treatment based on, and obviously we are talking about the ideal world situation where no financial
Yes.
burden or constraints are there. So in that scenario, I would consider osimertinib and chemotherapy as per Flora 2.
Okay. What is your choice about on Mariposa?
Yeah, I have no experience of using both the drugs, and in terms of considering, I think, quality of life and the toxicity, also my preference would still be osimertinib and chemo.
Dr. Sandeep, are you there?
Yeah, I'm there.
Yeah, so this patient doesn't have any brain mets. So again, the same question. Only osimertinib plus chemo versus Mariposa.
What was his EGFR type?
L858R.
L858R.
Exon 21, yeah.
Yeah.
Considering the exon 21 mutation, though it's a subgroup analysis where the Flora trial showed that the osimertinib PFS and the OS was not that great compared to DEL 19. And being the Flora 2 data is very encouraging, I would offer this patient osimertinib with chemotherapy. And your next question, the Mariposa, obviously, I had asked you this question before also, because we were part of the Mariposa 2. The only issue with the Flora 2, I find, this is my question, like when we are giving a OC with PEM carbo, and if the patient progress, we won't be able to use Mariposa 2 in the patient's treatment history in the second line. So that's my question to you or to Dr. Nadal, like how to tackle that.
So, Dr. Nadal, can you come up this question? So, if you are using Flora 2 in first line, then other than the new ADCs, we are not being able to use Mariposa combination versus Flora only first line.
Yeah, I think if the patient has been exposed to platinum-based chemo, but many of these patients, they progress many months later, then you can consider to re-challenge chemotherapy again with carboplatin, pemetrexed, and having access to amivantamab, that could be a reasonable option to repeat platinum-based chemo plus. But it's true that another emerging options that is interesting to me also is ADCs in these patients that they have been already exposed to. But at this moment, for example, in Europe, we don't have access to ADCs, only in clinical trials. But we have been able to participate in some of these studies, like Tropion-Lung15, and other studies with sacituzumab tirumotecan. And I think the efficacy of these anti-TROP2 ADCs in EGFR mutant disease is quite nice. Despite there are toxicities and we need to also learn to manage that are inconvenient for patients, I think that will be probably a very interesting approach. But that is in the ideal world that we have access to those therapies. But I think some people is criticizing to use Flora 2 because then what I am going to do afterwards. But I think that is not the best way to go because as my colleagues commented, this patient is a young patient that is fit, has exon 21. The volume of the disease is not really high, but probably is a patient that is young, has a couple of children, and probably for him, I think every day matters. And I think a treatment that can extend overall survival, I think, is important. But I think it's something that we need to discuss with our patients and bring our conversations to the discussion of the benefit and harm and decide with them that probably it makes sense to assume some of these toxicities to gain also PFS and overall survival.
Dr. Nadal, I have one question. Like, suppose this patient would have been DEL 19, and first, two questions actually. DEL 19 with such low volume disease, would you go for FLORA or FLORA 2? And suppose the patient progressed with the FLORA 2 with a vivid metastasis, and are you comfortable only changing the osimertinib to amivantamab because the patient will be on the OC with the pemetrexed maintenance? So are you comfortable in changing only the OC to the amivantamab and adding a platinum? Are you comfortable in your practice?
Yeah, the problem what we are concerned is about the brain control, and then we know that once we incorporate chemo and we remove the third generation EGFR TKI, we were expecting that we could lose some control of the disease, but to me it was very provocative, the results of the Mariposa 2, that adding lazertinib added more toxicity than benefit. Then you have much more GI and skin toxicities and even more thrombosis when you have the triplet, all the therapy together. And then it's true that we have the risk of that we are not controlling so well the brain when we remove osimertinib. But to me, I think it's not clear that we should maintain the GFR TKI once you add chemo plus amivantamab, because I think there is a risk of harming the patient, because I didn't see much benefit and there is a significant increase of the toxicities. But it's true that we need to be then very careful in terms of following the patients with brain MRI every 3 months and to see that the patient are not failing in the CNS. But I am comfortable with that. It is true that I am comfortable, but on the other hand, I am also following closely those patients because you don't want to have this brain progression that we know that has a significant impact in the quality of life.
Thank you. I think the challenge remains both for FLORA 2 and Mariposa. If you're using amivantamab lazertinib versus FLORA 2, anyway, second line option remains mostly the ADCs or depending on the resistant mechanism. Because neither of this case you can give again amivantamab. On FLORA 2, if someone is on pemetrexed plus amivantamab, and when they progress, you can rechallenge carboplatin, but what happened to the other chemotherapy? Is it paclitaxel? Probably no, because we don't have any data. So again, that challenge is there. But if you're using osimertinib alone in first line, definitely the option is there. But the PFS benefit definitely much higher in FLORA 2 or Mariposa as compared to only FLORA. So for a fit patients, especially with this risk factor like here, exon 21 or someone with brain mets or TP53 high burden, is worth using a dual agent in upfront. Either of these, depending on accessibility and comfort zone of a treating physicians. Mostly remains that once they are progressed, and they will progress at a long time, you have to do rebiopsy, find the on-target, off-target resistant mechanism. You can treat accordingly. Mostly is a MET if you're using FLORA versus non-MET pathway if you're using Mariposa. And now the newer clinical trial, we have at least two. At least the TROP2 inhibitor shown activity is now approved, and you have other combinations. So I'll go to Dr. Sunil. Dr. Sunil, this patient was treated with osimertinib, and now he has progressed.
Means,
so, how do you go about?
Means actually these patients once having a resistance, means this combination is a very good combinations.
Yes.
But the important thing is that once this fail, the patient is having no scientific option. Clinical trials, as Professor Nadal mentioned about that. You can try anything, but if you see the scientific basis, we are not having any options. And these patients progress within a short period. And these patients deteriorated. Even the brain mets will be seen in a short period within 3 to 6 month period, or you can say during the treatment part. So it's very difficult to say which is the scientific way, but you can apply the clinical trial as an option in such patient if failure with the FLORA 2.
Yes, sir. 20% they will have MET amplification, and we have the data from Savannah study and other study to use MET inhibitor along with osimertinib. We are also part of this Savannah study. And there are case report of MET, FRET, ALK, MET exon 14, all types of secondary resistant mechanism. Case report, case results, they are using dual TKI. Those are very rare scenario. Maybe as a conglomerate, it will be less than 10%. Majority, as you said, Other than the small cell transformation, majority is the off target, and we don't have any target therapy other than the clinical trial and the TROP2 inhibitor as of
Yes.
now. Right, sir. So,
Yeah.
Kunal sir, any comments? How do you treat the post-osimertinib failure? Any personal experience?
First of all, I must say, not a lot of patients that I see are able to afford even
Osimertinib,
osimertinib,
right?
which is a big challenge. And second, now the second aspect is OC with chemo. Again, this is ideal dream kind of patient that you would see 55-year-old ECOG 1. Most of my patients, when I am called to see them in the chest ward or in the medicine ward, are oxygen dependent, are ECOG almost 3, if not 2. And we are struggling even to consider single agent TKI.
Right.
So I think these are the practical challenges. These are good data to have. We have to understand and know the data, but I think the real picture is totally different. And when the limited number of patients that I have on osimertinib, in terms of progression, one, if they are single site or like we call about oligoprogression, I
Progression,
am
yeah.
managing them with the local form of therapy
Immunotherapy.
and considering continuing osimertinib. And those who have a true multi-site progression will be candidates for anything that we can give at that time
Mostly
in terms of
chemotherapy.
chemotherapy.
Yeah, right. And then that's a fact. If you ask me, most of majority they'll end up in chemotherapy because we don't have access to the majority of the clinical trial. We do not have access. Not everyone can undergo a good liquid biopsy or biopsy with further NGS and further target therapy. If someone has access problem to osimertinib, they'll have more problem to dual TKI, and that's a fact, right? Thank you very much. I think let's move on to the case 2. So thank you, Dr. Kunal and Dr. Sandeep, for this panel discussion. So let's move on to the case 2. Can we have the introductory slide for second presenter? I think the second case will be presented by Dr. Esha. Dr. Esha is Associate Professor of...
Yes, sir. Good evening, sir. Good evening, sir.
Good evening, good evening. Are you there?
Yes, sir. I'm there.
So Dr. Esha is Associate Professor and Medical Oncologist from KGMC Lucknow. She will be presenting the second case. So good evening, Dr. Esha. Please go ahead.
Good evening, sir.
Yeah.
Can the organizers please share the slides? Next slide, please. So, good evening, everybody. I am presenting the case of a 56-year-old female with a very good performance status, a non-smoker, and with no significant comorbidities. Presented in August 2020 with chronic cough, found to be having a right lung mass, and the lung biopsy showed adenocarcinoma, and the mutation came out to be positive was L858R. Next slide, please. So here we can see that there was no intracranial involvement and single right-sided clavicular bone metastasis, and the right lower lobe primary is visible with N2 as well as N3 disease. Next slide, please. So the patient was started at another center on erlotinib 150 milligram, which she was taking once in the morning, and this she started in September 2021. She continued till September 2021, and we can see a partial response on the CT 6-month post erlotinib. Next slide, please. Patient had a grade 1 dermatitis and grade 1 diarrhea. No other significant toxicities. So if we compare from the August 2020 scans, then partial response was the best response to the first line treatment. And then the post 3 years on erlotinib, patient developed progressive disease in August 2023. And the sites of disease were the lung, bones, and lymph nodes. Repeat lung biopsy again showed EGFR L858R positive, and it was negative for T790M. Uh, at the center where the patient was being treated, she was offered pemetrexed plus carboplatin, to which she had a stable disease as the best response. And then she was put on pemetrexed maintenance from January 24 to August 2024, after which she had a progressive disease and she declined further repeat tissue biopsy. Next slide, please. And the liquid biopsy in August 2024 did not show any actionable alterations. And she was again re-challenged with pemetrexed and carboplatin, and she again had a progressive disease after 3 cycles. Then she was offered docetaxel, with which she developed a grade 3 fatigue, and she declined to continue further chemotherapy. She was offered best supportive care, or enrollment in a clinical trial. Next slide, please. After which she came to the other center for seeking a second opinion in December 2024. And even then, the patient's performance status was still quite good, and the patient had a dry cough and mild dyspnea on exertion, otherwise largely asymptomatic. And the disease was there in the lungs, lymph nodes, and pleura, as well as the right clavicle. She was offered a repeat biopsy for profiling, and osimertinib was also offered to her, which she started. She opted for osimertinib, actually. Next slide, please. And then she developed a grade 1 paronychia. Otherwise, she tolerated it well. She resumed her mountain climbing, and we can see a clear difference in these scans. Next slide, please. Right about 1 or 2 months straight away after starting osimertinib. Okay, thank you.
For this I would say this is a kind of atypical case profiling, but yes, nicely managed. So we have a panel discussion. We have 3 panelists, Dr. Saurabh Kumar Misra, Associate Professor, M. Bhuvaneshwar, Dr. Prashant Mehta, Senior Consultant, Program Lead from Amrita Institute, Faridabad, and Dr. Tanmay Mandal, Medical Oncologist from Manipal Hospital, Kolkata. I can see Dr. Saurabh. Prashant, are you there?
Yes,
I
yes,
can see Prashant also.
Hello, how are you?
Hi, good evening,
Hi.
Prashant. Good evening.
Hi,
And
Good to see you.
Dr. Tanmay? I can't see Dr. Tanmay as of now. Anyway, nonetheless, let's go ahead. Let's Dr. Tanmay join. So I'll first. Good evening, Prashant. How are you?
I'm good, sir. How are you?
Good to see you. And good evening, Saurabh.
Hi,
Nice
sir.
background, by the way.
Long time. Thank you, sir.
Thank you.
Hi,
So,
Saurabh.
can someone put the slide, the case 2? First slide or second slide? So this is a patient with a N3 disease, was L858 beta positive but non-metastatic. So maybe the patient was not fit for CTRT, kind of, then was started on allortinib. So, and then progressed, T790M negative,
Did the
given
patient not have a
chemotherapy.
clavicular metastasis?
See, yeah, there was one single bone
That's
metastasis.
Okay,
I think
sorry. There are
it was
single
an
bone
oligo
metastasis.
sort of. It was an oligo.
But still
Yeah.
metastatic.
Oligomets.
So it's
Oligomets,
not.
yeah.
So let's discuss at that point of time. So started on allortinib and then progress T790M one time negative, progress on 2 line of chemotherapy, PEM carbo, intolerance to docetaxel, then re-challenged with osimertinib and had a response. So Prashant, how do you see it? Do you will give osimertinib to this patient, or you want to do some test before starting on osimertinib?
No, I think yes, the liquid cell-free has been done for T790M for this patient, and it was negative, I believe.
Yes.
Till she was started on osimertinib. So yes, I would always do a liquid followed by a tissue if liquid is non-contributory. So we generally try to biopsy the progressing site, the most progressing site, and then we try to find out the mechanism of resistance with whether it is a mutational issue or it is a histological transformation.
Right.
And I have really come across a few histological transformations of late also, and that is something which we really need to find out if there is a rapid progression.
Yes.
And a small cell transformation is what commonly we are seeing, and then we obviously use chemotherapy and carbohydrate like regimens. But in this situation where the disease has been slow, indolent, the progression has not been so quick.
Yes.
And the cell free is not showing a T7, the CTD, the CTTN is not showing, filing is not showing T790M, and the patient has not tolerated chemotherapy. This is a very specific situation. And there is data to the effect that some modest activity of osimertinib would still be there, and probably this patient has gotten lucky and has responded to osimertinib. And I cannot say that I have never done it. And also there have been patients which we have there was a recent very interesting situation which if you have the time I can share, if you have the time.
Yes,
Can I
yes, please
share a
go on.
situation? Yeah. So this situation was with a lady who was on Jeff Pem Carbo for nearly 2.5 years, and she was in CR. And somehow, although I had recommended the lady, she was a young lady with no children, I had recommended them not to get pregnant, and use contraception, and all those precautions were there. But she got pregnant, and she came to me with the reports showing a pregnancy, and she wanted to continue pregnancy, and we consulted our fetal specialist, and I recommended that she cannot continue and she should obviously get MTP done, but she was not willing, and she stopped all her anti-cancer treatment and went to the gynec fetal, and everything was happening. And then I was kind of left like an observer. I was just seeing her in the OPD and monitoring her disease. She was in complete remission by then, and the remission was also maintained for nearly about 2 years when this happened. 6 months of pregnancy, she was in her hometown and she had some headache. I asked her to come back to our Faridabad, and she was in somewhere in Punjab at that time. And we got the MRI done. There were 3 4 big lesions in the brain, and there was a midline shift, and she was heavily symptomatic. And she had severe headache and all those raised ICT features. And without batting an eyelid, I just put her on osimertinib. I did not do anything else. There was no time to do anything else. I had started Dexamani, and I started Aussie. And obviously, then we had to take the matter up with the family. She underwent a termination of pregnancy at that point in time. And then it is from that time, it is about 1 month now. I sent her for SRT and all the brain targeting treatment and all subsequent workup. The CTDN still has not been done, but the lesions are now nearly there is no lesion now. They're very small and they have responded already. So this is one situation when you have because the CNS activity of Aussie is very good.
Yes.
So even in the absence of T790M or a situation which merits a rapid escalation of treatment, Aussie can still be a good drug here. And like the situation I was in, and this particular patient, indolent history, slow progression, again, doing Aussie was not wrong, I felt.
Yeah, thank you. So, Dr. Saurabh, is it possible that the patient developed T790M later? Because we know there is a dynamic, it do change later.
Yeah.
And every time you have to do, either the VAP was still high, that means there are some cell who are still EGFR dependent pathway, or the patient has developed T790M. Otherwise, it's not, we not do routinely give osimertinib unless there is no other options. So
Right,
how do
sir.
you want to treat this patient? Any different way?
So one thing I was just thinking, I actually take a lot of treatment options for local therapy, pending that lot of our patients will not be able to take these drugs. So when there is a limited sites of disease and the patient has responded pretty well to TKIs, probably I would consolidate with some form of local therapy to the bone, to the metastasis and the primary. The second thing what we have done of late is that we have tried to continue the TKI beyond progression. So suppose the patient has still a mutation which is sensitive, I can continue nilotinib and I can then add the chemotherapy, or I can continue osimertinib and then I can add. And there is some good data that yes, we can do that pretty well as Professor Nadal, and there is some experience. So that is what we have been doing for our patients.
Yeah, it's a kind of modified FLAURA2 or modified chemo-JEF. Like
Yes.
once you start on
Yes.
TKI, add on chemotherapy unless there is a excessive
The
disease or
rapid progression,
yeah,
absolutely.
right,
And it
right.
has
Dr.
helped in
Bivas,
Yeah,
improving.
yeah,
sorry to interrupt you. I just wanted to let you know, sir, Dr. Tanmoy has also
has
joined.
joined.
Yes, sir. Sir, and
Yeah,
also, sir, requesting if you,
2 minutes. We'll finish in
sir,
2 minutes.
yes, sir, yes.
Right. Dr. Tanmay, are you there?
Yes, yes, I am there.
So have you seen the case? So this patient, L858 beta positive, progression allogeneic, no T790M in one biopsy, progression on chemotherapy, intolerant to docetaxel. Patient was challenged with osimertinib and then responded. Have you encountered this type of response in your practice? And what is your usual practice for those patients progress on first or second generation TKI but T790M negative? How do you treat them?
So, say if the patient is T790 mutated and the patient has behaved, or the patient's disease has behaved in a very nice way, or it's an indolent form, even if it's T790, I plan to initiate them on osimertinib. And actually, I had one patient who was on since 2020. He was on jeftinib till 2022. That time, only EGFR ALK and ROS were done in 2020. Then in 2022, the patient progressed, and we did a repeat biopsy with NGS, and it showed T790. It was positive for T790M mutation, and we initiated on osimertinib. And now the patient has passed 3.5 years on osimertinib, and again has progressed. Now we did a liquid
Yes.
biopsy this time. Still, it's EGFR positive with T790M positive this time also. And next is to plan, and the patient is probably will not be affording for AMI plus chemo. So I will be probably planning for a PEM carbo plus osimertinib at this point, because the patient has never been subjected to chemo, and he is not affording for AMI plus chemo also at
So
this
I have one
moment.
question. You want to continue the osimertinib here, right?
Yes, yes, I wanted to continue the
Why?
osimertinib. The reason is that he has a progression mostly in the bones. I mean, he had this bone metastasis at on progression in 2022, and now the progression is mostly in the bones and a single liver mets. And a single liver mets, we did a liver biopsy which showed it to be adenocarcinoma. And I have sent the and the liquid biopsy showed it this T790 still positive. The reason is that although it's a progression, but it's not that Florida progression, and the PS is zero as on date. The PS is still zero.
So one
So
follow-up question. Do we
yes.
look at the VAP of the EGFR to decide whether I want to continue the TKI or not?
So VAF, I think we should.
Let's say you have done this patient, the VAP of EGFR, whatever mutation is 0.5%. Still you want to continue the TKI unless there is no brain mets?
So I think with a low VAF, I am not sure that how much it will help in continuing
Yes, that's
the
the question.
TKI. But taking the biology of the patient, disease biology of this patient, I
Okay.
feel that it's better to
Still continue EGFR.
continue,
Okay.
as the biology was so nice. When says so much good response.
Thank you. So I'll ask take expert opinion from Dr. Nadal. Dr. Nadal, what is your input or suggestion on this patient? Where we want to give empirical osimertinib, or where you want to continue TKI in spite of progression? How do you decide?
Yeah. Yeah, I think I had similar cases, and as my colleague said, when they have indolent disease and you suspect that you may have a false negative result of the T790M, I think it's reasonable, particularly in these patients that they even have tried chemotherapy and the tolerability is not so good. Many of our patients, probably in India is the same, are elderly patients that they are quite frail and scared of chemo. And in this case, if I cannot do a biopsy of the tumor, because some patients it's really difficult because they have these very little lesions in the lungs and bone lesions and difficult to biopsy. In those cases, I tried and had some nice experiences too. I think what is important also when we do the liquid biopsy is to see if we were able to identify the initial mutation, because if we don't find anything, that I think that
can be.
yeah, probably that is a false negative. And we don't have access in Spain to NGS in the blood, but if probably in India, I don't know, maybe not some academic centers they have, but we will have the tumor fraction or an indicator that you have an informative sample. I think that is, but if we are not, we have a liquid biopsy is negative. We cannot do a biopsy, and the patient is still happy to receive a therapy. I think trying in those cases, I think makes sense to me too.
Yeah. Thank you. Thank you. So I think thank you all our panelists for good discussion on this case too. So we are running late. So we'll move to the next part of the topic. So can you someone? Yeah. So next we have a panel discussion. I'll invite moderator Dr. Sunil Kumar Gupta. Sir is a principal director and HOD, Medical Hemonc and Bone Marrow Transplant, Venkateswara Hospital, New Delhi. Sir, good evening. I can see sir from start of the meeting. He's waiting for a long time. So sir, the stage is yours. Thank you. Sir, you are muted.
Thank you, Dr. Biswas. Very good evening, dear friends, ladies and gentlemen. At the outset, thanks the organizer, Dr. Biswas, who has given me this opportunity. We have discussed a lot about from Dr. Nadal, and we have two cases. We discussed about the FLORA 2 as well as the other trial. The question is which one you will apply in your clinical practice, and both are category 1 recommendation. Is a driver mutation, Puja positive for deletion 19 or L858R. Then question is, as per the present era 2025, the guideline says both are category 1. Which one you will select? And for that, I have two experts basically. My colleague Dr. Sajjan Rajpurohit, who will tell us about the FLORA 2, why he want to give FLORA 2, and another is another expert who will discuss about the bispecific role in those patients, those who are having a driver mutation positive as a category 1 recommendation. We have 8 minutes, and each expert will discuss the trial in 3 minutes, and 2 minutes he can reply the question and answer, and 4 minutes are basically for rebuttal rounds, and ultimately we'll conclude what is the present era in 2025 despite of a category 1 recommendations, what is the choice and why, discuss in detail. For first discussion of FLORA 2, I would like to call my colleague Dr. Sajjan Rajpurohit. He is a Senior Director, Medical Oncology and Head of the Department of Medicity, Noida. And I would like to call Dr. Sajjan Rajpurohit to discuss FLORA 2.
Thank you, sir, first for the kind words. And without wasting much time, I'd like to start my case here. So I can see can I just see it again because it was, now I can't see the presentation. Can you put up the presentation from your side? Can the organizers put the presentation? So like we have been hearing from the experts in last meeting, and a lot of discussions already happened upon which we tend to choose practically. Though we have 3 options there, we know that for EGFR mutation positive patient, we have 3 options. Next slide. But then clinically, when we see our patients, we see that a lot has changed in EGFR space over the last 15 years. And now we have drugs which are either TKIs, we have ADCs being a part of the first line management of EGFR positive lung cancer patients. Next slide. We have seen that consistently using first, second, and third generation TKs have shown improvement in PFS as well as in OS. And if we talk about FLORA 1, because FLORA was a landmark trial, and it showed that starting from anywhere between OS of around 22 months, we reached OS of 38.6 months only with one TKI, which was osimertinib. And that was, I think, the kind of a landmark kind of a trial, which actually shifted all of us wherever practically and financially feasible to start using osimertinib, and wherever a patient could actually afford and we could give, we were inclined to give osimertinib. And now we have almost 10 years data with the osimertinib, and it has shown to be consistently one of the most preferred choices if you have to use a single agent, especially for low volume disease or where we don't want to use a triplet combination. Next slide. We know that, okay, so this trial we have discussed amply, so I'll not waste much time here, but it has shown that even with single agent, the hazard ratios of PFS were 0.46 and OS was 38.6 months versus 31.8 months with a hazard ratio of 0.80 and p-value of 0.045. And CNS penetration of this drug was so high that PFS was not reached versus 13.1 months. And it's very important part of the management because it's very important to recognize asymptomatic brain metastasis early on and continue to have control of new brain metastasis in these patients. Next slide. Now, it was realized that we could improve the results of osimertinib, and we had data where first generation, next slide, when first generation drugs like Jafnib were combined in landmark trials, especially we had TMH study, we also had another study with Jafnib, where it was found that if TK was combined with chemotherapy, it delivered superior results. Next slide. And based upon this data, we had this logical conclusion to have Flora 2, which was designed with the same scheming that adding chemotherapy to such effective chemo TKI could actually improve the PFS and OS. And then came in Flora 2, which was for patients EGFR mutation, advanced metastatic non-small cell lung cancer, chemo or treatment naive, and who could have stable CNS metastasis, which was one of the very important part of this trial, and had Asian, non-Asian population, and patients were either put on osimertinib versus osimertinib plus pemetrexed with platinum. Next slide. And you can just see here, almost 40% of the patients had CNS metastasis at baseline. And actually, I would agree this that many of our patients actually have, if we just keep on having MRIs at baseline, we will find that almost 35 to 40% of our patients will have either asymptomatic brain metastasis. And that's a very common early metastasis which happens in EGFR positive TKI, EGFR mutation positive lung cancers. Next slide. Next slide, please. And this showed that compared, go back, please. Go back, please. Now, if we talk about the PFS, there was a difference of 8.8 months at 24 months follow-up. And even at follow-up, the difference was maintained at 9.5 months. Osimertinib plus chemotherapy had a significant and clinically meaningful improvement in the PFS versus osimertinib monotherapy. Next slide. And if you just see all the curves here, so I think the one has been a discussion about L858R. But if we just talk about almost all the areas of the subgroup analysis, they were all favoring hugely the use of osimertinib plus chemotherapy versus osimertinib. And the consistent benefit was seen across all subgroups with the addition of chemo to osimertinib. Next slide. Now, if we talk about the difference, if we just talk about now we have two trials which we are discussing. So if I talk about Flora, where Flora and Mariposa both had comparator osimertinib. Now, if I talk about those cross trial comparisons, sometimes they're not very, I would say, encouraging. But if we just see the kind of patient population, the Flora had a difference of almost 10 months, 9.5 months in the PFS, compared to only 7 months in the Mariposa study when it was compared. Hazard ratios, if we talk about hazard ratios also were favoring the Flora 2, which was hazard ratio of 0.62 versus 0.70. Next slide. And based upon mutation also, you can just find that there was no difference in the mutation benefit, and both del19 as well as L858R, the most common EGFR mutations, had a hazard ratio of 0.60 and 0.63 respectively. So there was a consistent improvement in both these important EGFR mutations with the addition of chemotherapy to osimertinib compared to osimertinib alone. Next slide. One more important aspect, if now you compare this to Mariposa, and as I told you that 40% of patients would have some form of brain metastasis, and you can find here CNS efficacy or intracranial PFS was markedly improved in the Flora 2, which is hazard ratio of 0.47, whereas Mariposa, there was not clinically improvement. There was a separation of curves, but hazard ratio was only 0.79. So a better intracranial PFS was observed with the combination of these therapies compared to monotherapy, and median PFS improvement was of 11.1 months in the osimertinib versus or in the Flora 2 study, whereas this difference was not significant in the Mariposa study. Next slide. And also you can see the complete response rates. If you talk about monotherapy, it was 16%, whereas it jumped to almost 50%. So complete response of 48% was seen. So it was the responses were early on, and a complete response was seen in almost 1 out of 2 patients in the triplet regimen compared to osimertinib monotherapy. Next slide. T50 is known as a poor prognostic factor, but if you just talk about if T50 was mutated, again, you could just see that the adverse effect of T53 was relatively ameliorated by use of this triplet regimen compared to the monotherapy. So patients who had monotherapy versus chemotherapy, though they had a median PFS which was similar, but then we could see the separation of curves happening in the later follow-up. So it was irrespective of baseline T53 being positive or negative. So that factor, poor prognostic factor, was annulled by using combination therapy. Next slide. Again, extrathoracic metastasis has been a negative prognostic factor, and that also was ameliorated by use of this triplet regimen compared to osimertinib. Next slide. Even patients who had high tumor burden is again a poor prognostic factor, and osimertinib plus chemo doublet showed PFS benefit in patients with high tumor burden. Next slide. Now coming to a very important landmark, which is OS. And OS, even at 4 years, if we talk about the OS, the difference of 49% versus 41%, and an absolute delta of 9.9 months was seen in the triplet regimen compared to osimertinib alone, which was again a landmark. And you could just see that the curves kept separating with the increase in follow-up. Next slide. Next slide. Next slide. Next slide. So this slide shows that talking about safety, though no new safety signals were observed, and adverse event leading to discontinuation remains low, and no new treatment-related deaths were observed with the combination arm, though anemia, diarrhea, and some of the side effects were relatively higher in the combination compared to the monotherapy. But none of them were that significant or grade 3 or grade 4 to lead to higher discontinuation rate for combination therapy. Next slide.
So मैं तारों में उसमें बैठा हूँ साइंटिफिक प्रोग्राम में 5 मिनट तारों.
Next slide. Can we go to next slide? Okay, this is the same pictogram. Next slide, next slide, next slide. So more or less the side effect profile was FLAURA2 was similar to our experiences with the osimertinib, and not too much toxicity added with chemotherapy. Now, if I talk about Mariposa, patients had, if we talk about the differentiation factors, Mariposa had much more poor tolerance of therapy compared to this triplet regimen. Next slide. And based upon this, though they have been approved as the first-line options, again, osimertinib has been the preferred choice among all the clinicians, and wherever the tumor burden is high, whether it's extrathoracic disease, there's a pre-existing CNS metastasis, there's a high tumor burden, I think most of us tend to prefer osimertinib plus chemotherapy compared to what my colleague will tell you in the subsequent slide. And with this, I'd like to stop it here and give it back to the moderator.
Thank you, Dr. Sajjan. Now I would like to call Dr. Priya Tiwari. She will defend Mariposa. I don't know how she will defend on the basis of the trials results, as Dr. Sajjan Rajpurohit clearly says that FLAURA2, he is favoring that, but I want that. What is the Dr. Priya Tiwari opinion regarding the Mariposa trial as a category 1 recommendation in lung cancer? Dr. Priya Tiwari is the head medical oncology, Artemis Hospital, Gurugram. Dr. Priya Tiwari, please.
Thank you, sir. I'll just share my screen. Hello, Dr. Bivas. So is the slide deck visible?
Yes, yes, Priya.
So it's a very important question now that you have, the world has so many options now to offer to patients what to choose. we can just say that the drug is not available, there are cost issues, but for one patient, for one particular patient where the cost and the availability is not an issue, what are we and how are we going to choose? Now, the important thing is amivantamab is a recent addition to the list of drugs that we have been using. Chemotherapy, we are all very comfortable in using. So as a new drug comes to you, you learn to use it. So I think as of now, we are learning to use amivantamab. And as we grow, as we get more experience, I think we'll all become much more comfortable in using amivantamab. And so this common notion that yes, the chemotherapy, we are comfortable in using the chemotherapy, and that is how it should be, might actually change in near future. So we all just discussed that yes, osimertinib monotherapy has been a long-standing first-line therapy. It has a very good intracranial penetration, but we want better, isn't it? So Mariposa and Flora-2 introduced the escalation strategies. So they both demonstrated PFS in the OS superiority over osimertinib alone. The key question is chemo escalation versus biologic, that is the chemo-free escalation. And that is where the Mariposa actually scores. You have a chemotherapy-free combination, isn't it? When you're sitting in your OPD, when you actually break this news to your patient that the patient has an advanced stage disease, every time the question about the treatment and the word about the chemotherapy. So how are you going to make the journey as comfortable as possible? So the question is, many of the times the patients are actually not comfortable in taking chemotherapies. Also, sometimes some patients might have some other problems, like if you have a limited bone marrow reserve. So, you know, these amivantamab kind of drugs will actually help you to include more patients, to offer them some different kind of standard of therapy, which does not include chemotherapy. So just to highlight few important differences between the Mariposa and the Flora-2 studies, they are all well conducted studies. The important thing is that the Mariposa actually included regular brain imaging. It required serial brain MRIs for all patients, but Flora-2 only required brain scans at baseline and the progression for the patients without CNS metastasis at baseline. Mariposa evaluated PFS by the BICR and the Flora-2 evaluated PFS by the investigator assessment. Now, this is the much talked about the slide. The Mariposa showed PFS. You have an HR of 0.71 favoring the combination arm, the amivantamab lazertinib compared to the osimertinib. And importantly, that so you just saw in the previous presentations that there are certain high-risk groups: patients with brain metastasis, patients with liver metastasis, patients with detectable baseline ctDNAs, TP53 co-mutations. All these patients, they do very well with the combination therapies. There's also some subgroup analysis based on the L858R versus exon 19, where the L858R might not do as well as the exon 19, but we know that it's not that the subgroup analysis are just to give you some observations, and they are not very much practice changing. So most importantly, that I was actually impressed is that when you compare the results of all these on both the trials, though the cross-trial comparison should never be done, we do see that for the TP53 mutations, the combination did much better. And in OPD also, when you are sitting, you have to see that, oh, this patient has a TP53 concomitant mutations, and you know that osimertinib alone is not the answer there, isn't it? And yes, why not in the patient with brain metastasis? See, there are two problems with the lung cancer patient. First, many of them may present with brain metastasis. And second, many of them will ultimately end up presenting with developing brain metastasis. So you see a difference again here, and you need that kind of drug that even if the patient does not have a brain metastasis, you know that sometimes in future patient might develop brain metastasis. So you know you need a effective strategy to prevent development of brain metastasis. And here we do see a difference favoring the combination, 5.3 months versus 7.6 months. So what I'm trying to highlight here, that yes, this combination also does better in patient with brain metastasis, because this is also one of the reservations in using and choosing a effective lung cancer therapy. Better CNS controls always comes from penetration of molecules, intracranial penetration, which lazertinib has. And also, if you have a more effective systemic control, then of course the brain metastasis risk also goes down. Now you also have an overall survival from Flora-2 and Mariposa, and this was actually much talked about this year about the Mariposa trial. So you just heard about the results of Flora-2. The Mariposa trial brought in the overall survival results, and you can see here that the separation of curves are there, a wider separation towards the end, so sustained benefits, and you can also see somewhat a plateauing. So yes, the sustained benefits are going to help your patients too. This is something that we all want for our patient, isn't it? A confidence. This places us more confidence in choosing a molecule. more than 12 months projected median survival improvement. So median overall survival maybe more than 4 years. So this is something very important to see from this particular trial. Now, a big question about the toxicity comparison. We are just all quite concerned about the combination therapies toxicity. First infusion amivantamab, reactions. Then you will have a lot of skin toxicity, other problems, and this is where it is. But are we comfortable with chemotherapy toxicity? The hematological toxicity, anemia, neutropenia, thrombocytopenia, nausea, especially the first 4 cycles become so difficult for the patients. Yes, we do have amivantamab as well as lazertinib related toxicity, especially like I said, infusion related reactions, peripheral edema, the MET pathway, hypoalbuminemia, and you also have a subset of patients presenting with venous thromboembolism. But I'll just subsequently show you on the other slide that how we are becoming better at that. So just to sum up the side effects, Mariposa has rash, paronychia, stomatitis, infusion reaction, hypomagnesemia, flora-2 myelosuppression, fatigue, nausea. Fatigue is something that is much more seen with chemotherapy, especially the first 4 cycles when you have carboplatinum. And fatigue is something that one needs to fight. Because we don't have much medicines to offer other than some lifestyle modifications. So, but we have to understand the toxicities, isn't it? This is where the whole discussion evolves, that if the patient, the compliance is actually all related to the toxicities and ultimately the treatment outcomes. So the maximum incidence infusion reactions with the amivantamab happens with the first dose, and now with the skipper trial, we know how to manage them. The skipper trial actually showed that you can reduce the incidence of adverse drug reactions by using dexamethasone. Also for skin-related toxicities, now you have a proper cocoon trial-based protocol, which actually reduces the skin toxicity by more than half, both in the Asian as well as the non-Asian population. The flora-2, the problem is mostly the chemotherapy-related toxicity and the hair loss. Remember, a lot of these EGFR mutation patients are young, and many of them are females, non-smoker females, isn't it? So hair loss becomes a bigger concern for them. And this was the slide that I was talking about, that the cocoon trial actually brought in that how are you going to reduce the skin toxicity. The skipper regimen brought in that how are you going to reduce the acute toxicity. And you also now have a recommendation of prophylactic anticoagulation. See, I think most of us should always know and should always calculate a Khorana score for your patients. I don't think so that we are actually quite sensitized in using a VT calculation score in our OPD. But for last 1 year, we have started using that. And it's not just because of the drug also. I think we all should get a proper screening, a proper scoring done for our all lung cancer patients. And wherever you are using whether the score is high or where you're using a amivantamab, you should always get a prophylactic anticoagulation. So these are very important, and that is why I keep highlighting that when you're using a drug, the more you use it and more you realize that there are studies to help you decide how to use the drug, you become much more confident. And as the studies have shown that mostly the toxicities are during the first 4 months of the therapy, and then they reduce drastically. So yes, that is where it is more important. Now with chemotherapy also, because you have doublets in the first 3 months, so the toxicities might be higher. But sometimes pemetrexate, even with after sometimes intermittently could be a challenge. Like I had to discontinue because of a grade 3 renal toxicity in 2 of my patients this year. So chemotherapy can have ongoing problems, and it's not just it's just present in first 3 or 4 months. Now this is something which is very important, and how are you looking at the resistant mutations? So Mariposa has a dual pathway blockade, isn't it? The amivantamab blocks the EGFR as well as MET. Lazertinib blocks EGFR kinase activity like osimertinib, and also has activity in T790M mutation. Now this simultaneously suppresses on-target EGFR resistance, MET driver bypass resistance, which is one of the most common early escape routes, and MET amplification is the dominant acquired resistance after osimertinib. So this is where, you know, this combination actually suppresses all of them. And this was also seen by in this particular study too, from the Mariposa. So you see the incidence of MET amplification. The acquired MET amplification was 3-fold lower, and the EGFR resistant mutations were 8-fold lower for this combination. So this is what is very important, because this is using this drug combination is not leading to a more resistant mutations, it's not leading to a aggressive disease biology, which we all want. And now this is what you need to see, the TP53RB1 loss. So what are the independent resistance mechanisms? There are certain like HER2 amplification, RAS-RAF, but you have to see, we are all, you know, very much fearful of if there's a small cell conversion, isn't it? So the TP53RB1 loss is actually is a pointer that there is a small cell conversion, and you see that incidence so low here. And the small cell is something, if patient develops a small cell, we know that beyond some chemotherapy, some immunotherapies, nothing else works. And this is the most deadly form of resistant pathways. And we see that here by using this Mariposa protocol, you're seeing a lower incidence, a much lower incidence of this particular pathways. Also, what about the complex alteration? So while using this combination, you see much lower incidence of the complex alteration just by using in comparison to osimertinib alone. So these are quite a very strong pointers, because when you are treating a patient, you have to think about the future also, about the sequencing also. And this becomes very important to look at what could be the resistant pathways. Now in FLURA2, it says because it's a cytoreductive technique, there's no specific pathway suppression. The chemotherapy combination reduces tumor bulk, delays clinical progression, do not block specific molecular escape pathways. And so the resistant pattern after the FLURA2 still does dominated by the MET amplification, EGFR tertiary mutations. So chemo delays progression but does not overall change the kind of mutations happening at the time of risk. Now something very important, logistics and challenges. Now lazertinib and the osimertinib, their oral formulations can be given with or without food once a day. Now important thing is amivantamab. So the trial said, the Mariposa trial said once a week followed by once in 2 weeks. So people say that the frequency becomes quite difficult. Chemotherapy is just once in 3 weeks, isn't it? But now you have a subcutaneous formulation. So it actually becomes very, very convenient. The subcutaneous formulation decreases the time by 5 hours versus 4.8 minutes. And also the subcutaneous formulations decreases adverse reactions, the infusion reactions. Also some data is there, they also decrease the risk of venous thromboembolism. So subcutaneous formulations might actually become much more popular with time, and eventually they'll help this combination to be more patient friendly. Also because there is just no chemotherapy involved, you did not give the patient GCSF support, there is less stringent monitoring of the blood parameters. Now something very important in the FLORA2, what about the chemotherapy compliance? Now this is the graph to show that with each loss of pemetrexate cycle, you actually lose on the efficacy. So it's very important that you do not miss on the pemetrexate, and chemotherapy compliance becomes very important. So somehow if you feel that, you're giving osimertinib, but a lot of it is also decided by chemotherapy. And sometimes in actual practice, it becomes quite difficult to use chemotherapy and the compliance may be an issue. But remember, you can only derive a trial result if you're able to maintain this kind of compliance, because with every loss of a cycle of chemotherapy, the results might actually suffer. So the Mariposa has now opened doors to treat stage 4 non-small cell lung cancer with very effective chemotherapy-free combination regimen. It has proven role in patients with aggressive disease subset, that is TP53, patient with liver or brain metastasis. And most importantly, resistant pattern don't convert into aggressive subtypes. Results combined with other studies have also shown ways of reducing infusion reaction, skin toxicities, DVT, and with subcutaneous preparation, time and convenience will improve with further reduction in side effects. Thank you.
Thank you, Priya. Now, Dr. Sajjan. She has given so many evidence.
Yes, sir. So, first of all, I would like to congratulate Priya to put up her case very well. So, there are 3-4 things. One thing is that she talked about alopecia. I think with PEM and platinum, there's not much, alopecia is not usually a bigger problem. That's number one thing. What I would like to agree with her is that there are some patients who actually would have a pre-existing renal dysfunction. I think that's where I might also not be very happy to use chemotherapy, and especially pemetrexed, as she rightly mentioned, that could be really nasty for such patients. But if I talk about toxicity, definitely, even if it is a chemo-free regimen, which is amivantamab plus lazertinib, but my own experience with amivantamab has never been great at all, even despite use of steroids and infusion. Because it's not only the infusion reactions, it is the overall tolerance of this drug is not that good. But if we talk about osimertinib plus a platinum along with the pemetrexed, if the patient otherwise good, the renal function is not problematic. I think that's where the patients don't have any problems for the first 4 cycles, and most of the chemotherapy toxicity is well manageable. And I think as clinicians also, we are mostly happy using this combination compared to user, as you rightly mentioned that the word was chemo-free regimen. But I would also tell you that not everything which is chemo-free is definitely safer. So, and also talking about the evolution of clone. So I think that's the main reason why chemotherapy is added to osimertinib. It prevents the coming up of a small cell transformation. It also that is the role of chemotherapy, which it prevents the bad prognostic part of that, or the tumor. It takes away tumor heterogeneity. I think that's the reason why chemotherapy adds a lot of benefit to osimertinib. I think the same reason why they have been trying to use a chemo-free regimen. So the concept with which Mariposa was designed was fair. I think the point you've taken is good, that it was a the purpose was to give a chemo-free regimen in the first line. But still, as a clinician, if I have to choose between both of them, in most of my cases, I'll choose osimertinib with chemotherapy compared to amivantamab plus lazertinib. So that's my rebuttal to you.
Thank you, Sajjan. Now I would like to take an opinion of Professor Nadal regarding the Flora 2 versus the Mariposa. What is the choice in Barcelona by professor in their patients? I would like
Yeah, our experience in Flora 2 comes more from the clinical practice, while or the combination amilaser has been more in clinical trials. But I think amilaser could be also an interesting option for patients that you want to skip chemo, as Dr. Tiwari said. For example, I am considering this option, for example, for patients that are very elderly, that chemo is poorly tolerated, and I don't want past. I was not using geriatric assessment in EGFR mutant disease because I have osimertinib. Then I have a very well tolerated pill for all patients. But now that we have more options, I think it's time to recover also oncogeriatric assessment, and I think having a chemo-free option could be interesting for some patients. But it's true that at this moment, we will not have any trial comparing directly, and we will have our own experiences. And I must say that I have patients that they tolerated quite well amivantamab lazertinib, but many of them, they have a lot of problems in the skin toxicities mainly, and also in the way the patients that I have been treating for a long period of time with amivantamab, the edema and the hypoalbuminemia is a big problem in some patients, and then you need to skip doses, and then when you skip doses, as we don't have yet subcutaneous amivantamab, and then once you re-challenge again amivantamab, you have reactions again. Then it's a bit tricky. It's not so easy, and you need to have a well-trained team to manage all these troubles. I think it's a good option too, Mariposa, but it probably is going to be much more demanding. And then probably from a public health, in our country, that we have a public health system, and in India, that I know when I talk with my Indian colleagues, that you have so many patients in your clinic. I think that is also important. That in terms of which is our ability to tackle of these problems that we will have, because one problem with Mariposa is that patients come a lot to the clinic because they have a lot of issues, and then that is something that then. If you have a good team in terms of nursing support or patients that they can call, your nurse can call them, and you have a good connection with other skin doctors or other members of the team, I think that's great. But if not, probably you will have a lot of issues. But on the other hand, I must say that chemo in some patients is really well tolerated, but I had patients that they have a lot of problems too. And then I don't want to, I want to give a balanced view that I think at the end, we are still in a very empirical era, that we will have several options, and we have to discuss with patients, and we have patients that they behave very well with these intensified treatments, but we have patients that we need to be very careful, because it's true that some of them, they can be admitted in the hospital with the combinations, and I think it's important to discuss that with them. But for me, it makes sense because we are gaining survival time, but the trade-off is also important for some patients.
Thank you, Professor Nadal. You are basically maintaining a balance between these two, Flora versus the Mariposa. I personally feel it's a individual medical oncologist decision as per their patient choice, condition, comorbid conditions regarding the selection of this drug. Each trial is having their own benefit as well as some limitations, but there is no head-to-head trial. I would like to say it's a choice of the medical oncologist to decide about Flora 2 versus the Mariposa in such patient. Thank you very much for such discussion. I would like to hand over the mic to my organizer, Dr. Biswas, for further discussion.
Thank you, sir, for moderating a good debate. So, two things on the debate. I'll go for a patient exchange program with Dr. Priya. So, all the Flora 2 comes to me, all the Mariposa goes to Priya. I think I'll be the gainer at the end of the day. Number 2, टॉपिक कुछ भी हो, प्रिया से तो कभी डिबेट नहीं करना है, बिकॉज हमेशा वही जीतेगी. So I'll stay away from Priya for all the debates. Nonetheless, it was a very good debate. So thanks, Dr. Nadal, thanks, Dr. Gupta, thanks all our panelists and who has presented the case discussion. It was a very good topic of discussion, all the aspects of EGFR positive advanced NSCLC, mostly the choice of therapy in today's time. We have good options, so that is one of the good part. Second, we have confusion because we have many options. So sometimes it is make our life difficult, but at the end of the day, it is good for the patient. And we have now the challenge is what to do post osimertinib or post Mariposa failure. Thanks to the ADC and the newer upcoming clinical trials, I am sure in next couple of years we have more option in post osimertinib failure or post amivantamab failure setting. So I thanks AstraZeneca for giving me this opportunity. I thank you all. We'll see you again. So stay happy and good night and take care of your health. Thank you.
Happy Sunday, everybody. Good night.
Thank you.
Happy Sunday. It was
Good
a
night.
great pleasure to be with you this evening.
Yeah, same
Thank
here.
you, sir.
I learned a
Thank you.
lot.
Same
Thank
here.
you. Thanks a lot.
Thank you.
Thank you so much. Thank you.
Good night.
Bye.
everyone. Bye.
Good evening.